and welcome to our third annual Research Day hosted by the Ministry of Health and Social Services. My name is Sharice Allen, a social worker within the Ministry of Health and Social Services. And today I have the pleasure of being your MC as we explore some of the most pressing health and social care issues affecting our communities, from maternal health and aging to reintegration, antibiotic use, and much more. Ladies and gentlemen, before we delve into this morning's proceedings, I would ask that you please stand as we give honoring to one of our national symbols, the territorial song of Montserrat, Motherland.
Oh, Montserrat, dear motherland, your children raise your standard high in toil and tears to serve you well, a crowning jewel from God's hand. Oh, Montserrat, by nature blessed, to you your children sing. Come, well of all, come, friend of all, to you your people cling.
Please be seated. So today is a very interesting day, a day where the Ministry of Health and Social Services provides you with an opportunity to be stimulated intellectually and to be exposed to evidence-based practice. This event brings together researchers, health and social care professionals, strategic management, policymakers, and community voices to shine a light on what the data is telling us, and more importantly, how we can act on it. But before we begin this morning, just a few housekeeping notes. Firstly, please keep all mobile phones on silent. Restrooms are located downstairs on your left upon entrance, and we encourage you to take notes. At some point in time, we will also invite you to ask questions, and we value your sterling contributions, so please keep that in mind. We will allocate at least 5 brief minutes for discussions, and then later on, we will have more extensive discussions if needs be. We're looking forward to a full day of insight, learning, stimulation, and connection. But before we begin today, I will give you just a snapshot of the agenda for this morning. So we have some expert researchers, and we have first, opening the baton series, Dr. Shara Greenaway-Jibri, our Chief Medical Officer, and then we'll move swiftly along with Miss Gretelyn West, Dr. Tiffany Scarrett-Fleming, Dr. Sinclair Coward, Mr. Bill Berners-Lee, Mrs. Charmaine Gray, Dr. Dorothea Hazer-Blake, Mrs. Kerry-Ann Weeks, and last but not least again, Dr. Sinclair Coward. Thereafter, we'll allocate some time for some further discussions, comments as to how you felt about our presentations today and how we can improve going forward. And then lastly, our acknowledgements before we conclude today. So our first presenter for this morning is Dr. Shara Greenaway-Jibri, our Chief Medical Officer, and she will be discussing human papillomavirus DNA-based screening on Montserrat. Our first presentation focuses on a virus that affects many, but is often hidden in silence, HPV. Dr. Greenaway, over to you.
Okay, good morning, everyone. I am going to try to contain my excitement about this study. But I know. Firstly, I'm happy that Ms. Allen highlighted what HPV stands for, just to make sure that everybody understands what we're talking about. So, human papillomavirus, and we know that it's linked to several cancers, so including cervical cancer, penile cancer, vulval cancer as well. But today we'll be focusing on cervical cancer, and let's just get right into it. So, our population, 4,396, based on the last census. It was 4,386. I'm told that we've gained 10 people, so that's exciting to know. We have 1 hospital, 4 health centers. We have lots of satellite sites as well where we offer care, but just to focus on what we primarily offer, as well as there's a small private sector. And I mention these because this is where we do our screening for cervical cancer. It's usually pap smears, and in some women, if it's indicated, we will do HPV testing. So this is what was happening before we did the prevalence study. It was very ad hoc, not a formal screening program. So like in the UK, women would get like a letter or notification that they need to come in for screening. So this is what we are trying to develop in the Montserrat setting as well. But before we get to that, we kind of had to understand what was happening. So what we would do is take the sample on island, so we'll do the swab, but we'd have to send it overseas for testing. So the traditional pap smear, as well as the HPV test, because we didn't have the testing supplies. We onboarded a gynae oncologist in 2024, and I was particularly excited about that because to have that subspecialty is actually quite rare in the region, so we are very fortunate. And we had the donation of a colposcopy machine in 2023 from Helping Hands for Glendon. So the colposcopy machine allows you to visualize the cervix in more detail. You can locate the abnormal cells, and you can actually do sampling and further testing and diagnostics from that tool. We also have limited cervical ablation available. So after you do colposcopy, the gynecologist may recommend that you undergo a procedure called ablation, which literally means they're burning or removing the abnormal portion of the cervix. We launched the vaccination program against HPV in 2017. Unfortunately, it was halted. We had some vaccine hesitancy at that time. We also, eventually ran out of vaccines. And vaccines, we can have a whole presentation on that for the Montserrat context, because we also have challenges in meeting the minimum order requirements through the mechanism that we procure vaccines for. So our lovely Dr. Tiffany Skerritt-Fleming did really know what our prevalence is. And if we want to develop a proper screening program, or even embark on cervical cancer elimination, you first need to know what your issues are. So what's our prevalence? And so that is how we embarked on the journey of our HPV prevalence study. We were lucky enough to get assistance from UKHSA, so that's United Kingdom Health Security Agency, and we are also part of their lab strengthening project under their UK Overseas Territories program. So they assisted us with technical support. So we had a dedicated epidemiologist. We also had support for the lab, and if lots of you might be familiar with John Lee, he has visited Montserrat several times, so he was part of the team. And we also got assistance from their behavioral science team under UKHSA. So they looked over our participant leaflets, for example, just to make sure that the wording was appropriate. We got financial support from them, so the testing kits, the HPV test kits, and other miscellaneous costs. So let's get into the study. What were we trying to look at, what we were trying to achieve? So we wanted to estimate the prevalence of HPV infection, especially high-risk genotypes, because those are the ones that will progress to cervical cancer and the other cancers that I mentioned before, in women of screening age to inform our future plans. So we wanted to estimate prevalence of HPV in women aged 25 to 64 years. We wanted to describe and compare the demographic characteristics, especially associated with high-risk HPV. And, interestingly, we wanted to estimate the number of women who would be willing to undertake self-sampling and determine whether if this was an acceptable way of doing testing going forward. So what I mean by self-sampling, so instead of a woman going to the doctor and lying down on the gynecological bed and having a health professional take the sample, women were allowed to do the sample by themselves at home with clear instructions. So that was really interesting. And I'd like to put a plug here that Montserrat is one of the few countries that has actually explored this in terms of their prevalence studies. So it's a cross-sectional prevalence survey, inclusion criteria, women aged 25 to 64. You were excluded if you lived in Montserrat for less than 6 months, and you are aware that a subset of our population migrates depending on the time of the year. If you're outside of the age range, of course, if you had a history of hysterectomy, that's removal of the womb, and other areas as well. If you were pregnant or less than 3 months postpartum, and diagnosed with any cervical issues relating to cancer. We were aiming to sample 208 women with an estimated response of 30 to 40%. We used quantum GIS, the same that they used in the census for 2023, and we were aiming to sample 520 buildings. Quite a significant task. And recruitment occurred between October 2024 and March of this year. So we went to different households, randomly selected, of course, and we administered a short questionnaire, so just basically gaining demographic details from the women. And then we asked them if they wanted to do the test themselves or if they wanted an appointment to go to a health professional to have the test done. In terms of the lab, all of the samples were tested at the Glendon Hospital Laboratory using the Gene Expert PCR platform. And this would be one of the benefits from COVID-19. So we're still benefiting from, the capacity building that we would have experienced during that time. The assay used detected 14 different types of high-risk HPV. The negative results were given by phone, and if you had a positive result, you were given an appointment to see the gynecologist for further management. We analyzed the data using chi-square test. We did age-adjusted prevalence for each high-risk HPV, and we used regression to calculate odds ratios and the 95% intervals, and we used R to perform the analysis. So I put this slide in here just to show you the algorithm that we would have followed. So if a woman tested negative, she will be followed up in about 3 years, bearing in mind that this might change now that we have the full study report available and based on new and emerging evidence out there. And if you tested positive, then you will have colposcopy done, like what I explained before, and then based on your colposcopy result, you'll be managed further on. So usually women who have a positive result, you'll be seen, based on your management, you'll be seen 12 months after, once you've completed your management cycle. And so that algorithm on your right shows you the algorithm for that. So let's get into the results, the meat of the matter. So we visited 260 households. 35 were deemed not eligible, so that left 225 women. 19 declined to participate, so we had 206 women consenting initially. 19 eventually withdrew from that, and we had a total of 187 samples submitted for testing. 159 tested negative, and we only had 28 positive results. What I want you to focus on, though, so on your right at the bottom, look at that whopping 96% of women who decided to opt for self-sampling. So majority of women decided, nope, I don't want to see a health professional. I feel empowered enough to do sampling at home. As a matter of fact, some of these women, after they consented and they filled out the questionnaire and they were handed the test kits, they're like, hold on a minute, ran inside, did their sample, gave it back to the enumerator, which was absolutely fantastic. And so here we go, ladies and gentlemen. Our overall age-adjusted high-risk HPV prevalence in Montserrat is 14.6%. So how does this compare to the region? So it varies from country to country. Of course, they have their other factors that would influence their prevalence, but we're slightly lower. Most countries are high teens into the 20s. We have some countries that are reporting high prevalence rates like in the 40s. So that's where we are. We also found that if you were in the age group between 25 and 34 years, you had a fourfold increased odds of testing positive compared to the older group, which, if we really think about it, is not really surprising. And we did not find any other characteristics that was of significance for a positive result. So, where do we go from here? So now that we know what our prevalence rate is, 14.6%, we can now say that, yes, we do have high-risk HPV in our population, so we need to do something about it, right? So we're going to consider what our screening program is going to look like, that formal screening. In the meantime, the ad hoc screening continues to occur, and we still do pap smears. But we're going to determine what that screening program should actually look like in terms of your age, what test should you get, if it's pap smears, should we just offer HPV testing across the board, and all of those things would have implications for the age at which we start screening for cervical cancer. So, since self-sampling is acceptable to the majority of women, we need to consider this and find a way to rope it into our screening program. How we go about that, though, would be very important, because the follow-up, there was a subset that we had to do lots of calling, lots of encouraging, remember to submit your sample, that sort of thing. So if we're going to do that, we really need to think about how we distribute our test kits. You know, is it that women have to pick it up? How do we make it as convenient as possible? And at the same time, how do we make sure that we don't waste test kits? So that, you know, women, they pick up a test kit today and then like 3 months later, it's there and it probably is expired and we end up wasting supplies. And then, of course, the follow-up that is required for that. You know, do we need to have, not extra staff, but how do we have our staff support that sort of follow-up without it being burdensome? And then, of course, we want to recommence our HPV vaccination program in both boys and girls to ensure coverage later on. One of the things that was showcased in our prevalence study is that we don't have the more common ones that you would hear about, HPV 16, 18. We have it, but it's not our highest, it's not the most prevalent in our society in terms of high-risk HPV. So we now have to look at the vaccines that we are going to procure and ensure that we have adequate coverage for the population that we have. So, next steps. We actually have a cervical cancer elimination plan in draft. We were just waiting for the results of this study. There's still a lot of work to be done. There's stakeholder consultation that we need to conduct as well. But as I said, we want to develop a formal screening program, recommence the vaccination program. We have a phase 2 of the HPV project with UKHSA, and that is to purchase additional HPV test kits. We are going to purchase some additional accessories for the colposcopy machine that we have, and we're going to get ablation equipment that is WHO certified. All of this will concrete our elimination plan, and it will actually put us in a position to be like the first world countries, we hope. And we also want to share the results of the study. So presenting in this forum is one. Yesterday, I got the good news that we submitted the study for a journal publication, so we hope that we're successful with that, so that we can at least share, because the HPV prevalence surveys in the Caribbean region are actually not that common. So it would be good to at least contribute to the regional pool of research. And of course, we'll do some social media and radio adverts. So I'd like to acknowledge all of the staff on the Ministry of Health and Social Services that contributed to it. I listed out some there, but trust me, there are many, many more. At the end, I just put other, because we all came together. It took a lot of work. Special thanks to UKHSA for their support, because without them, this would not be possible. And to the study participants, a special thank you to all the women who agreed to submit a sample. Just know that you are appreciated and you are contributing to local and regional research. That is fantastic. And to the Tourism Authority, special thank you for the lovely photos in this presentation, the one at the beginning, and this lovely one of our Sophia Hills volcano. Thank you very much, everyone, for your attention. Wait for questions.
Thank you, Dr. Greenaway-Dubry, for those insights. Understanding the prevalence is the first step towards prevention and better public health strategies. And we're happy to hear that Montserrat is a part of the leading cohort in terms of self-sampling, and that some adjustments will be made towards the screening program. We will allow any burning questions for just 5 minutes. Let me say a special good morning to Mrs. Penny Maloney, who will keep me in check in terms of time. I forgot to mention earlier that each presenter will have a maximum of 20 minutes, and she will give me a warning sign when we have 2 minutes remaining. Any burning questions this morning? Comments, briefly?
Mine is not a question, it's more of a comment. And I want to congratulate Dr. Greenaway on standing and holding fast when it comes to this approach. Because HPV, she said it nicely. Back in 2017, there was vaccine hesitancy. She used nice words. There was pushback. People vex. People quarrel. People say we want to make the young girls sexually active. All sorts of things. And at one end, and that we were trying to, there was also another side that said we were trying to make the women of Montserrat infertile with this vaccine. Where they got evidence from, I am not aware. But at the other end, from some of our regional stakeholders now, there's a push. Can we do this? Let's do this. Other countries are doing this. But we like to throw around words like evidence-based practice. And this is a very good example of making sure we have the evidence. Took a whole year, it took more time, and sometimes we want to jump in and do things. So I think we should congratulate ourselves on the approach. We took the time to get the evidence, and now we have not anecdotal evidence, but empirical evidence that says 14% of the women sampled have high-risk HPV. So then now we can make a decision. Is this an acceptable rate? And we can say, okay, so we don't need the vaccine, or is it not an acceptable rate that 14% of our women may actually go on to develop cancer? And I think for that, the ministry should be congratulated.
Thank you, Dr. Blake. Any more questions? Comment? Please stand.
Thank you so much. My name is Bami Shile. I joined in congratulating the ministry, but my comment is just to ensure that we have a holistic follow-up approach and wellness to those small figure population who have tested positive. to the investigation. We know that even as small as anxiety expressions and all that could follow the individuals that were reported to be positive. So at the point of disseminating the information to them, at the point of follow-up with the gynecologist and ensuring that we want to follow up to the last letter, I would suggest that in following up for future, I don't know whether the gynecologist has referred or probably in groups to actually manage issues of anxiety or whatever psychological attendant we may have within that small population. That's just my comments. Thank you.
Thank you very much, Dr. Bamishile, and I am sure that Dr. Greenaway-Jubri will consider those remarks made. Let me also take this opportunity to say a special good morning to some of our online viewers, whether you're watching by way of the comfort of your homes or even your offices. We also encourage you to participate. You can leave your comments and your questions, and at some point today we'll address those if time permits. We're going to move along. Our second presenter is Miss Grethlyn West, one of the stalwarts as it relates to medical records, and I think she's also considered to be a third-timer for our research day, and so we give her a round of applause for her sterling contributions over the past 2 years. And she would be presenting today on the topic birth outcomes and maternal chronic illnesses. This would offer some insights into chronic illnesses amongst mothers and how it's affecting birth outcomes and what interventions might help us here today. Thank you very much. Come, please.
Good morning, everyone. Today, Bill, Lystra, Jeanette, and I would like to greet all those present, as well as our listening and viewing audience. Today's presentation is entitled Birth Outcomes and Maternal Chronic Illness. What prompted us to conduct this study? In 2024, a local birth study found that low birth weight was greater than 7%. This was higher than the 3% rate recorded in the United Kingdom, and so we decided to investigate further to understand the possible cause. Low birth weight and preterm birth are adverse birth outcomes associated with long-term cognitive developmental problems in children. Stillbirth is another adverse birth outcome that can have profound effects on the mental and physical health of women, impacting their emotional well-being and relationships. On the other hand, hypertension and diabetes mellitus are well-established risk factors for adverse birth outcomes, including preterm birth, stillbirth, and low birth weight. Some terms to be defined are as follows. Stillbirth. In our region, based on age of viability, a stillbirth is defined as a baby who dies after 28 weeks of pregnancy, but before or during birth. Preterm, also known as a premature baby, is born before 37 weeks of pregnancy. Low birth weights are babies who are born weighing less than 5 pounds, 8 ounces, or 2,500 grams. Gestational diabetes is high blood sugar that develops during pregnancy and usually disappears after birth. Pregnancy-induced hypertension is high blood pressure that develops after 20 weeks of gestation. The aim of the study was to evaluate risk factors for birth complications in Glendon Hospital maternity care. These are the three objectives. 1, to estimate the incidence of adverse birth outcomes, that is preterm birth, low birth weight, and stillbirth over the last 15 years from 2010 to 2024. 2, to estimate the rates of hypertension, both induced and existing, and diabetes mellitus, including gestational and pre-existing, among pregnant women in Montserrat over the same period. 3, to estimate the incidence of adverse birth outcomes by maternal hypertension and diabetes status. This was a retrospective review of maternity and neonatal records for the period under review. All births on island during the study period were included. Deliveries less than 28 weeks of gestation were excluded. Data was analyzed using the statistical software R, and analysis involved calculating prevalence and incident rates with 95% confidence intervals, then plotting these on bar charts. Consent was sought and approval received from the Chief Medical Officer to conduct the study. Here is a summary of the data. For the last 15 years, there were 678 deliveries. Regarding maternal risk factors, 11 mothers already had diabetes before getting pregnant, while 24 developed diabetes during pregnancy. 30 mothers had pre-existing hypertension, and there were 56 with pregnancy-induced hypertension. In terms of adverse birth outcomes, there were 4 stillbirths, 47 low birth weights, and 53 preterm babies. This chart shows total births and number of low birth weights from 2010 to 2024. Most births took place in 2010, 62, while the highest number of low birth weights were recorded in 2015, 8, and remained steady at 2 in 2023 and 24, respectively. To answer our first objective, that is, incidence of adverse birth outcomes, we found that 11.8% of all births were affected by at least one adverse outcome, either preterm, low birth weight, or stillbirth. The most common adverse outcome was preterm birth, accounting for 7.8% of cases, followed by low birth weight, 7.2%. Stillbirths were rare, occurring in only about 1% of cases. Here, we can view graphically the overall adverse birth outcome rates in our study population. Objective number 2, rates of maternal hypertension and diabetes mellitus. 12.8% of mothers were diagnosed with hypertension, making hypertension the most prevalent risk factor. The majority of hypertensive cases were pregnancy-induced, 8.3%, compared to 4.6% pre-existing. 5.2% of mothers had diabetes, most cases also being gestational or pregnancy-induced, 3.5%, versus 1.6% chronic. This chart is displaying how common diabetes and hypertension are among mothers. Each bar represents a specific maternal risk factor. for targeted, data-driven interventions to improve maternal and neonatal health. Recommendations. To start, family support is very important in pregnancy. Therefore, husbands, partners, families, and friends, we encourage you to accompany mothers to clinic visits when possible. Help her with household chores so she can rest. Learn the signs of danger in pregnancy, example, bleeding, swelling, and severe headache, and know when to seek help. Watch for signs of sadness or stress and encourage her to talk about her feelings. Celebrate and encourage her. Remember, positive words means a lot. Recommendation number 1. Given the 12.8% prevalence of maternal hypertension and its association with low birth weight, we are encouraging clinicians to continue the following: routine blood pressure checks at all prenatal visits, administering low-dose aspirin for high-risk pregnancies as recommended by the World Health Organization, education on hypertensive disorders such as preeclampsia, especially first-time mothers, referring mothers with severe hypertension for specialist care from the...
Fine. So that's my comment. Thank you very much.
Thank you very much, Dr. Pass. Ms. West, I'll invite you to give a response briefly.
The data we got from the UK was related to, was collected from their census. So we didn't have a lot of information as to which gestational age they included, what was included. And secondly, that's why we are promoting preconception counseling, because we know prevention is important.
Hi everyone, Dr. Mara here. Now, what I wanted to ask about the preconception counselling, that kind of assumes that the average woman is planning their pregnancy. And although I don't have any empirical data to talk about, anecdotally, I'm sure many or even the majority of pregnancies are actually unplanned. So how does that work with the idea of preconception counselling?
Well, preconception counseling, because we know it helps to improve the outcomes of mothers and children. We do acknowledge that we have planned and unplanned pregnancies, but we think it is important to give people an idea what to take into consideration if they're planning to get pregnant and how it can benefit them and their children.
We have one more question. We'll reserve the other questions until later this afternoon.
Okay, good morning. Gwethlyn and team, very good presentation, quite detailed, and I really enjoyed it. But I'm not sure if I missed if you did mention how many persons had both gestational diabetes, hypertension together.
Thank you very much, sister. And that's a good question. But our objective was to do for individual, but both diabetics and hypertensive. We did not, did a combination. Thank you very much for all the questions.
And thank you too for those comprehensive responses. Moving swiftly along, our next presenter is Dr. Tiffany Skerritt Fleming. a very diverse medical practitioner who has participated in many public health incentives, amongst other research projects. Today, she will be speaking on the topic, Better Answers, Fewer Antibiotics, What New Testing Means for Our Children. Dr. Skerrit Fleming.
Thank you, Sharice. Good morning, everyone, and to those joining us virtually as well. It's a pleasure to be here. So this morning, we've had two presentations so far focused a little bit on women or female health. And so we're going to pivot now to talk about a little bit about pediatrics. I know that Dr. Paz will be excited by that. So in 2022, when I returned, I decided to pursue my master's in pediatric emergency medicine, which I've now completed. So this is the topic that I chose. And I spend most of my time in casualty. That's my department. I love it very much. My nurses will tell you. And we do see a lot of children. So this is a rough outline of how we'll be going through the presentation. And the main focus will be those children who presented to the casualty department for acute respiratory infections. ARIs, as they are called, it's just fancy, but what it means is any child or any person presenting with fever and a cough within the last 10 days, whether or not they experienced any respiratory distress. So if you've had a fever and you've had a cough within the last 10 days, we categorize you under our surveillance as having an acute respiratory infection. So based on this definition, looking through the literature, we realize that this is a very common thing. ARIs are basically cough and colds. And within that category, we have tonsillitis, pharyngitis, sinusitis, all the itises that basically occur within the respiratory tract, whether they're upper or lower, right? And so we know that these are common conditions, and we know that it is a challenge sometimes when dealing with sick children and parents to decide on what we should treat them with. Now, the temptation when we see a fever and we suspect infection is to give antibiotics. And so in 2023, as part of the same UK HSA drive to improve our laboratory services, we got a new fancy machine called the BioFire machine. And this would have been added to our gene expert, which is able to identify specifically which organisms are causing the infection. And the aim with this study or audit was to look at how many children we were seeing through the department presenting with ARIs, and if the introduction of this new testing platform had any impact on our admissions for those infections or our use of antibiotics. So, what did we proceed to find? Well, they say that if you can't measure it, you can't improve it. And so the goal was to determine how many children with respiratory infections were being treated with antibiotics in order to see how we could make a change. According to the Global Burden of Disease study, an estimated 12.8 billion cases of these infections were reported in 2021 in all age groups. But in particular, children are the ones who are sick most often. Children aged 5 to 9 years represent the greatest volume of respiratory consultations. And if you think about it, if you have children, nieces or nephews, they're the ones who always have the sniffles, always have a cough, always have a fever. We've also noted that these infections are primarily viral, meaning it's caused by a virus, meaning that antibiotics, which treat bacterial infections, would not be helpful. In particular, we see several viruses over and over and over again. Rhinovirus, which is what we call our common cold virus. Coronavirus, which we're all familiar with. Yes, it did not pop up in 2019. It existed long before that. As well as other common viruses, respiratory syncytial virus, RSV, and influenza. And all of these are known to cause ARIs. In Australia, I wanted to ask the question of how often are these types of cases receiving antibiotics? And in particular for children, they're seeing basically 30%, 1 in 3 of their cases of children presenting with respiratory infections are receiving antibiotics despite the clear guidelines. In the United States, Bronchiolitis, which is primarily caused by RSV, a virus, they're seeing uptake of about 25%. So 1 in 4 of their children receive antibiotics despite us knowing the clear cause. And they receive, in particular, a group of antibiotics called macrolides, that's your azithromycins, etc. So POC, or point of care testing, means that at the site where you're doing the diagnosis, there is access to some form of test. And so at the Glendon Hospital Laboratory, we now have PCR testing available using the BioFire, GeneXpert, and lateral flow, depending on what we need to do. That allows us to identify what virus or bacteria is causing the infection, and therefore, we are able to minimize the need for other tests. The temptation is sick child, fever, looks bad, has a cough, give antibiotics. Or sick child, fever, has a cough, I should do a full blood count, I should do a chest x-ray, I should admit this child, but is that truly necessary? So, sought some ethical approval from our research board, and they said yes in March, thank you very much, to Dr. Greenway-Dubry and Dr. Hazel Blake. And the aim was to do 2 retrospective cohorts. We looked at children who presented with ARIs before we had the fancy BioFire machine, for 1 year and 1 year after. We looked for those presenting specifically to casualty department because that's where we have high uptake or high overflow of patients. And we looked at the period August 1st, 2022 to July 31st, 2024, and broke them up into age groups. Now, the reason for these age groups is, 1, because of risk factors. We know that the under 5 age group is particularly vulnerable. They're not necessarily immunized against particular viruses. They have immature immune systems. The 5 to 11-year age group, which is basically our primary age, and then 12 to 17, our high school age. And so these were the groups that we looked at. The primary clinical outcomes were, has the introduction and use of this BioFire testing reduced hospital admissions for acute respiratory infections, and has it affected our antibiotic use? The main sources, I would have gone to the lab to pull that data from the BioFire machine. We've looked through our casualty triage record books as well as admission records, and with use of the HIS, we were able to compile the data set. So in total, we had 426, but there were only 424 that had complete information that we could use. 52.6% of the sample were female and 47.4% were male. And the largest group presenting to the department were our under 5s, which we expect, our smallest children, and you saw a decline over time in terms of those presenting with symptoms. What were the results? So for the 2 primary outcomes, we looked at rate of antibiotic prescribing and admissions due to ARIs. Specifically, in terms of quantity, we found that for antibiotic prescriptions, the rate declined from 21%, that's the orange tall bar on your right, before we introduced the BioFire, and decreased to 12.8% after the introduction of the BioFire. We found that when it came to admissions, there was no significant reduction in admissions due to respiratory infections related to the presence of the BioFire machine. So what do we say? There was no statistical evidence of difference. It didn't really show a major difference for admissions. However, there was statistically significant association, meaning the use of this diagnostic test actually made an impact when it came to antibiotic prescribing. And in fact, the reduction was 45%, right? So that was significant, and we're pleased to see that happen in just 1 year, pre and post. This was not primary outcome, but also important. We discovered that the less than 5-year age group were prescribed antibiotics more than any other group. So they were seen most frequently, and they were most likely to receive antibiotics. In particular, we love to use amoxil and augmentin, which is amoxicillin clavulanic acid. Those were the most commonly prescribed. However, in reviewing the data, it's important for me to share this. Even though we do surveillance for
6 who are very unhappy. Now, these are small numbers compared to the top, but these are individuals, and so they're having a tough time, and so they can't be left out because they're statistically quite low. Okay, but that's good news in terms of the older persons. What do we recommend? GOM to consider the introduction of a carers assessment. Remember that finding that says more older persons are caring for somebody else than receive care. Part of that may be what's on offer out there in terms of care, in terms of the care homes. There's literally nothing else or no one else to care for this person or persons if they don't do it. So we recommend GOM finance allowing, of course, and consider some kind of support for carers. Poverty in old age is a risk. Income security for older persons need to be an economic priority. GOM needs to develop effective poverty reduction strategies for older persons, most of whom we saw feel that they cannot survive on the income that they are having. So linked to that, we would ask for a review of the welfare pension levels, maybe introduce or consider introducing grants or concessions, allowances for a range of goods and services, especially health care related. We want some GOM and civic societies, charities, etc., to develop programs to provide access to daycare services where older persons can go and learn a skill, learn art, take part in activities. We'd like to review primary health care for reported accessibility issues for this group, especially dental, eye, pharmacological, in terms of accessibility, provision, and cost. We feel that GOM, through the Ministry of Finance, should provide approximations for the additional finance needed to cover demographic changes, meaning that Montserrat is an aging society. These issues that we saw here can only get worse. They're, especially in terms of healthcare. And so someone needs to sit down and plan for the next 5-10 years and look at the demographic changes coming and the associated costs that will follow that. We want to emphasize home care through supporting informal carers financially and with training. We've more or less said that. Ensure that group homes are able to respond to increased demand. So while you're supporting carers and trying to keep people at home independently, you also have to look to expand your group homes so that anybody who needs it, following assessment, can get it. So a lot of times, older persons are assessed that they don't have the requisite care package around them and that they need a residential environment. If that residential environment isn't there for them, potentially they could be at risk. We want to guarantee care services for those who need it. That means while they're at home in the community, which can help to prevent them going into group homes. So if you provide early care to those who need it in the community, that can prevent them going into group homes later on. And we'd like to disseminate the findings of the survey to the community to raise awareness about the needs of older persons. And not least because at the time of doing this survey, there was a number of other surveys going on. There was the national census still going on, and older persons were reluctant to admit another person to their home to speak. And so we gave them assurances that it was in their own interest because the results would be acted on, listened, considered, and acted on. And then they said, well, okay, we're doing it, but we want to hear from you, and we would like to see some comeback. So again, this forum is providing some of that we haven't, that their views haven't been given in vain, that we're doing something, but we need to move further and to take some action on that. So to conclude, this was the voice of older persons. This was primary research. We knocked on their door and sat down and got their views, and you can't get better than that. And so it provides a wealth, as I said here, of first-hand data about their strengths and the needs of the older persons in Montserrat. Overall, from this, they're doing well. They're happy, they're mobile, and they're healthy. There are, however, areas of need which we need to attend to. As I said, it's an aging population. These areas of need will get worse. They won't get any better. And the final statement here is not an overstatement to say that the ability of Montserrat to adapt to an aging society will be one of its greatest challenges of the 21st century. We know it has other demands on, on the finance, but this is, given the demographic changes, this is something that needs to be attended to and planned for so that come those demographic changes, we're ready. Okay, thank you very much. Thank you.
Dr. Kaur, don't leave just yet. We might have a lot of questions for you. Thank you very much for a comprehensive overview of the National Older Persons Lifestyle Survey. I think that it gave us some understanding, or it shed some light on how our older persons are living and what support might be needed, and most importantly, the need to have a more robust and responsive infrastructure that looks at the physical, financial, and social needs of our aging population. So open for questions now. Dr. Scarrett Fleming.
Hi, thank you so much for your presentation. I think just an observation I'd love to share is that for those persons 60 and over who attend a clinic or casualty department, which they tend to frequent, you'll find that healthcare settings are a social setting for those over the age of 60. It would be great, as you said, to create other environments. But what I've observed is that if you visit a clinic, for example, St. John's, on a Wednesday or a Thursday, they're congregating, they have their appointments, they look forward to the appointments with their doctors because it's an opportunity to socialize. And so within our healthcare system, especially our clinics, you'll find these communities where they try to coordinate their appointments, I want to believe so that when they come on this date, Coward is also coming on this date, Kim is also coming on this date, and it's an opportunity, therefore, to catch up, to socialize. We also find that within casualty, although our goal is to be an emergency department, that we have some frequent flyers who also use it as an opportunity to socialize, to interact. And they will come bringing their medications that they are very aware of, usually very well controlled, for minor, usually complaints, because healthcare provides them an excuse or reason to see nurse, to talk to someone, to have somebody interview them and see how they're doing. I think one of the ways to, especially for the casualty department, limit that type of frequency is to do, as you're saying, creating alternatives, spaces where they know they can go and see their friends. That doesn't require one of us to see them or, spend that time, but they appreciate it because it's, in healthcare, we are expected to care and we are taught to inquire, to ask, to find out how they're doing. So it's one of the ways to do that. The other thing I noted was that in terms of the illnesses stated, the heart disease column was particularly low and hypertension and diabetes were high. But one of the things we know that increases the risk of heart disease are hypertension and diabetes. So it'll be interesting to see how many of those clients, knowingly or unknowingly, are also being affected by cardiovascular disease, but may not state it as one of their complaints because it's not at the forefront of their mind. Several of them might also be on medications for their heart, but they don't connect those dots. So that's a potential loop that we should look for because we know that those persons are at increased risk as well. But thank you, insightful.
Thank you. And yes, you can't guarantee that people will be, you hope that people will be upfront and truthful in terms of the questions that you're asking them, but you can't guarantee. They may omit some stuff that, maybe they're embarrassed about or maybe they accidentally forgot, but you're quite right. in terms of that second point. In terms of the first point, you make the case in a sense, because what those people are doing who socialize when they go to other areas is taking advantage of the opportunity to, right. And so how much more better it would be for us to provide that opportunity, because you're only going to get a subsample of people who probably have to go there in the first place, but the others who may be at home and are well, and yeah, they're missing that out. So yeah, it's good. And as it said, it more or less agrees with the finding that a lot of people would attend such a service if we put it on. And so thank you for those questions anyway. Thank you very much.
Good morning, everyone. I would also like to add to what Dr. Fleming was saying, because dealing with the elderly, I realize that they are lonely. So I am probably suggesting that just as how we have a daycare for children, we could probably have a daycare for the elderly as well, a little recreational center, because not all the families really want to send their loved ones to a home. But because they're not able to care for them during the day, there is nobody there with them, then they have no other choice, because at the end of the day, they still have to provide. So what I was thinking is just a little daycare center for them, so the family can take them in the morning, give them the opportunity to socialize with the others, other people of their age group, and then pick them up in the afternoons. So I don't know, that's just my thought on it.
No, excellent, superb, yes, I agree. And that will keep people out of care homes, because sometimes the caring burden gets too much. And if relatives or even people in the community who are not related to those persons withdraw their service, a voluntary unpaid service, then the state would have no alternative but to place those persons in the home. And also in terms of loneliness, yes, we know it's a killer. There's been research that shows that it's equivalent, being lonely in old age is equivalent to smoking 15 cigarettes a day, the American, the equivalent to smoking 15 cigarettes a day. And we saw there also that a lot of older persons talk to people every day. And so it's not just talking to people, they're still lonely. They may talk to somebody, but they're still lonely. So that's something to think about. As we go, people may seem fine, they may look fine, but your neighbor, the person down the road who you see every day, are they fine? If you knocked their door and went and sat with them for 10 minutes or so and had a conversation, you'd be doing much more than you think you're doing. But it's still an area where I think the government, people should put their head together to see how can we tackle this issue. Thank you very much, the lady there. Yeah.
Hi, Dr. Greenaway-Dribry. It's a pity that we don't have more time to go into more detail, especially from the access to primary healthcare services aspect. Because looking at the age group that is focused for this, over the age of 60, a lot of the services are free of cost. So I'm actually wondering if it's lack of awareness or if there is another factor that is playing into this, because I know that some persons have issues with transportation. So is it that the
We've been finding in our mental health circles that there's also a concern about the quality of care. Is that something that you looked at in terms of the training of carers? Is that something that we've really looked into in your study or generally about the quality of care, as if they're trained, not only trained to care, but also trained to administer certain types of like medical checks and that kind of stuff?
That's an issue, and we didn't really look at it. We just enumerated the number of people caring for others. But we do know that there is an issue in terms of the quality of care. A lot of carers are informal and they haven't gone through any training whatsoever. There is a care certificate in existence, and one group has gone through that, and I'm not sure whether there's another one planned. Excellent. So it's been addressed. It's been addressed in terms of the care quality. And I should say not before time, but at least it's happening now, because the issue is not only to do with practicalities, to do with safeguarding and safety, lifting people out of the bath, taking care of intimate personal care for people. You know, you need to know how to do that and how to do that with, and have the person keep their dignity while you're doing it. So all that needs training. So thanks very much.
I got really curious about the ingredients concerning for older people to answer, I am happy, because you're saying that the majority of people stated that they're happy. But I would have been curious to find out what is making them happy. What are the factors, what are the ingredients that make somebody says, I'm happy? Is it because they're being visited by their grandchildren every day? Is it because they have a best friend who they're frequently on the phone with? Or is it a mental attitude, such as an attitude of gratefulness and expressing gratitude?
Right.
So I know it's a quantitative study that was done there, but I guess what I'm asking is a more qualitative deep dive into happiness and what is the ingredients to happiness. Because once we know what those are, we're in a position to work more on it in terms of what are the external things that go into people's happiness, and also what are the mental processes that happen within the person that makes them say, I am happy.
I've got you. You're right. Of course, you can do a whole new study on happiness and define happiness and break it down. But we just wanted to capture their first responses after having gone through all those questions which raise different areas in their life. We wanted to say, after all of that, after all of what you've told us, could you tell us about your state of happiness? And don't forget, there was about 48 questions, but I've only shared about 8 with you. And so we just captured their first response. But it was good to hear that, but we could delve deeper and that number may change. I suspect not a lot, though. I suspect a lot of people declare themselves happy despite not having enough money to live on, and despite not having access to healthcare and all the other things that you saw there, they're still happy. So that could do with more exploration, you're quite right. All right, that's it. Thank you very much.
Thank you, Dr. Coward, for your sterling contributions. And just a sidebar, the Ministry of Health and Social Services will be celebrating Month of Older Persons next month, October, and so we encourage the wider public to participate. You can adopt an older person during this month and provide some support. In addition to that, we are now at our well-anticipated break, and in keeping with the strategic agenda for the Ministry of Health and Social Services, I am pleased to announce that we have some healthy treats for you at the back, along with some beverages, and so we will give you 20 minutes, and so we ask those online viewers as well to do the same in whatever way you can. Take a walk, have something to eat, drink, and exercise a little bit, and we'll be back. As well as, I should give an apology to our online viewers, because I was meant to understand that we had some technical issues this morning, but I hope that the audio has now been restored. Thank you, technicians, for your support. And please remember, while you're grabbing your treats, your healthy treats, to sign our registration so that we can capture data, how many persons are in attendance, and so we can plan for future. So we'll now have our break. See you soon in 20 minutes.
culinary skills and cultivation skills. So people felt confident that they were able to grow fruits and vegetables to supplement what they could buy. And a lot of people, almost everybody who I spoke to some extent, grew their own fruits and vegetables. And a lot of people felt confident. I mean, the weather in Montserrat, I think, lends itself to growing fruits and vegetables quite easily, but also people felt they had the skills to do that. And then with people's culinary abilities as well, they were confident that they could do things like make their own seasoning that had reduced salt rather than just buying the seasoning in the shops that may be high in salt. Also, people felt very able to create their own drinks that maybe had less sugar than imported sodas or local drinks that you might buy in a restaurant. People also had self-devised strategies for behaviour regulation when it came to following DASH. So with respect to reducing salt and sugar, for example, people talked about things like diluting sweet drinks to perhaps reduce the sugar they're getting through the drinks, or using a spoon to measure out the sugar or salt that they're adding to their food or drinks as a way of regulating that themselves. However, there was a barrier here under this theme, which was about label literacy. Self-reported label literacy was generally poor, and this is about people's ability to read and understand nutritional guidance on the food that they're buying. Often people talked about, they'd say, tinned food has lots of salt in, but if I asked, would you know how to tell which tinned food is higher in salt than another product? They wouldn't really know. And I think that it's quite a technical skill, because to look at the back of a packet, it's just a number, and you've got to be able to know whether that number's high or low and what to compare it to. So people expressed a desire for greater education on label literacy. But people also did acknowledge that they could address these knowledge gaps using the internet and local radio, and a lot of people mentioned Penny in particular and Talking Health as a helpful resource. So another theme was cultural facilitators and barriers. So the first aspect of this was about social influence. This could be a barrier often, so people described family dynamics making it difficult to follow DASH. People talked about how it was difficult to follow a healthy diet if the rest of their family didn't particularly want to follow that diet themselves, especially if they had children. And that could lead to parallel meal preparation. So they'd cook for themselves and then they'd cook for their children or spouses separately. And that's obviously quite burdensome. But there was a facilitator that I haven't put on here, which was people talked about receiving social support when they had a diagnosis of hypertension. They got support from friends and family, and that helped them. So another sub-theme within this was about taste and texture preferences. So I put this under cultural barriers because a lot of people attributed this to culture and said, like, this is a Montserratian thing, was the way they often described it. So people talked about drinks with less sugar in being tasteless, or white bread was considered more tasty than brown bread. Brown rice was described as too hard. People didn't like the texture. And there was a strong preference for some of the fattier cuts of meat, like chicken wings. And people said things like, in Montserrat, we love wings and stuff. So I put that under sort of cultural barriers. But then there were cultural traditions that I think could be seen as facilitators as well. So people talked about cleaning chicken. This was a sort of practice I wasn't familiar with from the UK. I don't think many people do this in the UK. But people talked about while they're cleaning the chicken, they often trimmed away some of the fat from the chicken, and that's a way that they're making it healthier. There was also the long-standing inclusion of pulses in the diet is a very positive thing, I think. So, like people eating beans every day, and pulses are a really important aspect of DASH. So that was a facilitator, I think. But then people talked about their preference for white rice. They just said things like, oh, in Montserrat, we just love rice. You know, and obviously that's not perhaps a facilitator of DASH. And then there was another thing that I didn't categorize as a facilitator or a barrier, but this was sort of alongside conventional dietary strategies. People talked about strategies to reduce their blood pressure that were perhaps not based in science. And this would be stuff like people had a faith in bush tea and lime juice to reduce their blood pressure. And I hesitate to categorize this as a barrier or a facilitator because I think while perhaps it's not evidence-based, like DASH is, you can see ways in which this could be utilized to make people's diets healthier. If you can encourage bush tea over sugarier local drinks or imported sodas, that's obviously a positive thing. So I think that that faith in more traditional practices could be utilised to improve people's diets. And then this was the final theme, was about readiness to change and intentions. I think this was a facilitator. People had quite a determination to reduce their blood pressure. Of course, this is sort of affected by sampling bias. The people who I spoke to were people who had chosen to speak to me. So they were people who were interested in this. But I still think it's important because this reflects a contingent of people in Montserrat who saw change in their diet as effortful but worthwhile, and they considered things like the extra financial cost of healthier food being a rational investment in their health. And people said things like, it's better to spend the money on more fruits and vegetables, so you're spending less money when you're getting admitted to hospital later. So I think people, the people I spoke to had good intentions and strong determination. So, then I want to move on to next steps. So the key advantage of this theoretical domains framework, which is the framework that I used in this analysis, is that it lends itself to developing interventions. So there are existing tools where you can map factors within the theoretical domains framework to behavior change techniques that have evidence for effectiveness in addressing those factors. So, for example, social influence can be mapped to peer support as an effective intervention against barriers that would fall under social influence. So using this kind of methodology, it's possible to take the barriers that we've identified in this study and identify behavior change techniques with evidence of effectiveness against them. And these are basically building blocks for interventions. So then the next step would be to organize a stakeholder consultation where we can refine these behavior change techniques and develop interventions around them. A stakeholder consultation is really important because this is how we make this practicable. And there's an acronym that's quite good, APPEASE, which stands for affordability, practicability, effectiveness, acceptability, safety, and equity. And these are like all of the factors that you've got to consider when you're developing an intervention. And a stakeholder consultation is where we could flesh those out and make sure that behavior change techniques can be enacted in a practicable way. And stakeholders will be really varied. So that could be doctors and nurses, but also politicians, local radio, shop and restaurant owners, anybody who's involved in or affected by interventions. And another thing that I didn't mention here, but I also asked participants during the interviews for intervention suggestions themselves. So those suggestions could also be factored in because it's useful to get people's own suggestions as well so that they feel involved in the development of interventions. So that's everything from my presentation. I'd really welcome any questions or reflections on that.
If you have any questions, we'll invite you to come to the center where we have our mic positioned.
Okay, good morning, everyone. Dr. Skerritt, Georgette Skerritt, assigned to primary healthcare at the clinics. I don't have a question, just a comment. I want to thank Bill for this research. And it's important for us, especially our clients in the clinic, to see that their treatment plan involves not just coming to the doctor and getting your prescription, but also your diet, your lifestyle, all of that is important. So in going forward, we would continue to push more about their healthy diet, DASH diet for our hypertensives, and monitor and evaluate as to those who actually take it on, how well they're doing, and actually see if we can get practical evidence of improvement in their hypertension.
Very good initiative, Bill, and good work done. Now, I was invited to a workshop that was being done, a community workshop that was being done for persons with diabetes sometime last year at Cudgehead Clinic. And this kind of information was not available back then, I suppose, but I think that in terms of this information like this can play a big role in the awareness campaigns that are done here and the initiatives that are done to improve health and health outcomes. And I think it's useful to have the evidence from studies like these to play a part in those types of awareness campaigns and projects, so that we're not just using anecdotal evidence, but we're actually using the findings of empirical studies to inform not only what we're seeing, but how we can improve their outcomes. And I think that we also, in addition, we could use information like this in our public awareness, like in promotional activities, in our promotional drives. People hear about Penny's Talking Health program, but there's a lot more that can be done in terms of public awareness. And I think we also need to get away from, so this is just an extension, Bill, get away from strictly listening to the radio, because some people will listen this week, but they may not be available to listen next week when the program is actually aired. So getting out to the people and going where they are, taking information, is still a small community, taking information to them or at key information points. Clinics is one where they meet. At the supermarket might be a very interesting place. You know, in Barbados, we do sampling. We can also do promotions, health promotions at the supermarkets as well. So that's something that I want us to think about as we go forward.
Yeah, definitely. And I think the other thing that's sort of highlighted by this is that interventions can go beyond education and provision of information, because there are some barriers that are structural, like access to fruits and vegetables. You can have plenty of education, but if you can't access those things because you can't afford them, or they're not available in the shops, that's a barrier that's going to require a different kind of intervention. So I think the takeaway I got from this was that interventions maybe need to be a little bit broader, and we sort of need to think more outside of the box, perhaps.
Very good presentation, Bill. I think it was last evening I was viewing this doctor on Facebook saying when she was in med school, she was taught that if you were diagnosed with hypertensive, you could not get better. You would, throughout your life, you will be a known hypertensive. But she was testifying that based on, yes, some of the factors that you brought out, the diet, even the exercise, and as Dr. Bam would be happy for me to say, modifying your lifestyle, removing the stressor from you, you can be healed or get better. And she is saying she was testifying that she is one of those persons who had very high blood pressure, and once she removed all these barriers that were increasing the high blood pressure, she was able to be healed for like 2 years, not taking any medication, just modifying her lifestyle. She was free of high blood pressure. And she's saying even though for some persons they may not get rid of the high blood pressure, but instead of being on 6 and 7 medication, they can come down to 1. So yes, we are pushing the exercise, the diet, removing the stressors, and we can have a healthier nation. So just adding to what you have presented. Thank you.
Great, thank you for those questions.
Thank you very much, Bill, for a very insightful presentation. And I'm not sure how many of you would have paid attention to the presentations this morning, but Bill was actually featured in a number of them. We've been told that he's a whiz when it comes to data analysis. And so again, we say thank you for your sterling contributions, Bill. And yes, you would have offered some very sustainable solutions that we can all use and encourage our family members to maximize. We are moving on to our next presenter, one of our pioneer nurses, Mrs. Charmaine Gray, who will be presenting on COVID-19 and its effects on nurses in the United Kingdom. Nurse Gray.
Thank you, Cherise. Good morning, everyone. My last studying was in 2014 when I did my bachelor's, and I made the decision that was it. I had enough of studying. But then 8 years after, the itch came. Plus, I wanted to keep up to date with the boys, and so I decided to do something. So, in doing my master's, this was my dissertation, COVID-19 and its effects on nurses in the United Kingdom. Up. Okay, so some background knowledge. So in 2020, it was supposed to be the International Year of the Nurses, and it was intended to honor the dedication of nurses and midwives. However, what began as a celebration of nursing profession quickly shifted into one of the most challenging times ever faced by the profession with the emergence of the COVID-19 pandemic. Declared a public health emergency of international concern by WHO in March, COVID-19 led to widespread infection and death, prompting measures such as lockdowns, social distancing, and mask wearing. Nurses on the front line had to simultaneously manage professional responsibilities and personal obligations. This dual burden contributed to increased risk of infection, stress, financial strain, and mental health challenges. Many nurses faced income loss, emotional exhaustion, and disruption to their social lives while continuing to provide essential care. These conditions highlighted the urgent need for the effective coping strategies and exposed the pandemic's severe impact on an already overstretched healthcare workforce. So, my aims. What were the negative effects of the COVID-19 pandemic on UK nurses? What was the impact of the pandemic on the mental well-being of UK nurses? What were the social consequences of the pandemic for UK nurses in their personal lives? What financial challenges did UK nurses face during the pandemic? And how did the UK nurses cope to manage these impacts. Methodology. So the present research was a qualitative analysis of secondary data. In other words, I had to analyze data that was originally gathered by others and then summarize it. So I did a two-step selection process. The first one, I conducted a search of database such as ProQuest, Google Scholar, PubMed, WebMed, and Medline, and I used words like COVID-19, nurses, coronavirus, pandemic, UK, financially, socially, and mentally. The second step, I examined articles identified by the search to exclude any that were not relevant. I then evaluated each selected study individually based on its aims and objectives, methodology, main findings and conclusions, including their implications for practice. In total, I included 25 research papers in my final analysis. These papers were qualitatively analyzed using the NVivo 14 qualitative research software. So results, and we look at mental health impact. Nurses experienced significant mental health challenges during the COVID-19 pandemic, including heightened stress, burnout, anxiety, and depression. Contributing factors included fear of infected loved ones, lack of proper protective measures, working in unfamiliar environments, and emotional exhaustion from their expanded roles. Nurses were often redeployed to unfamiliar wards and faced high patient loads under conditions that made it difficult to deliver care in line with their training and values. So there are times where they would pull a nurse from a main ward and take that nurse to ICU. The nurse haven't gotten any ICU training, and so it was difficult to work in that environment. Female nurses were more affected than the male counterparts, not sure why, underlining the need for tailored mental health support. And I have two little clips of two different nurses. So this nurse, Shirley Watts, she worked in the ICU. She said, "We are on our knees here and it's really difficult." A second female nurse, "It was just exceptionally stressful. We all had the fear of taking home COVID to our relatives." Our social impact. Exhaustion experience was compounded by poor staff mix, postponed leaves, and unpaid overtime. Heightened stress, fatigue, and distress resulted from feeling torn between professional duty and personal responsibilities. And there were times limited resources and institutional support. One nurse, a registered nurse for 20 to 24 years, she said, "I remember sitting at my desk, phoning my husband, crying. As a nurse, I have to do my duty, and that was coming above my children." Another, "I am a single mother of a 12-year-old boy. I cannot remember the last time I finished a shift on time, nor had the energy to give my son the positive attention he deserves." Our financial impact. The COVID-19 pandemic exacerbated existing financial pressures on nurses, with many struggling to afford basic expenses and some opting out of the NHS pension scheme due to unaffordable contributions. Illness, unpaid work, and rising costs added to their burden, contributed to burnout and frustration. Despite these challenges, nurses continued to show exceptional commitment to patient care. However, the expectation that they fill staff gaps without compensation is unsustainable. And this is just a chart, a pie chart, which shows, as we can see, that mental, I think that go wrong. Yes, mental. We had more of a mental impact on the nurses. Financial was not so much, and in researching, I realized that they haven't done much research on financial, and then social take the second bigger half. So in concluding, the COVID-19 pandemic exposed long-standing issues within the NHS, which need to be addressed to retain current staff and attract new ones to the profession. These include low pay, staff shortages, and excessive hours. Recommendations. First one, provide psychological support by creating safe spaces where nurses can share experiences with peers or professionals, reducing isolation and promoting resilience. 2, implement clear policies, procedures, and training to prepare nurses for future health crises, following models like WHO's PRET initiative. 3, ensure nurses have access to essential tools and PPEs to perform their duties safely and confidently. And during the earlier parts of the COVID, they were lacking in the UK in PPEs, so they had to reuse these PPEs, and also the PPEs were given out based on the level of illness of the patient. So those in ICU, the workers, they would get PPEs to use, but nurses who dealt with other COVID patients, but they figured not as ill, they had to just work without any PPE. Encourage regular breaks to support nurses' mental and physical well-being, reinforced by managerial support. Develop strategies to attract and retain nurses, including incentives and targeted recruitment to address workforce shortages. Limitations. The review was limited to open access journals, so does not represent the full breadth of the literature. And over 65% of articles identified in the initial search were excluded, and the decision to exclude articles was taken by a single researcher, and this could have led to selection bias. Acknowledgement. I'm grateful to the University of East London for the opportunity to pursue this Master's in Business Psychology, and also to UNICAF, who funded a portion of my scholarship, and to the government of Montserrat for supporting the remaining cost for my master's. Special thanks to my tutors for their guidance throughout the program, particularly Miss Eleanor Iona Levatania for her dedicated support during the dissertation process. I also appreciate the encouragement from my family, managers, and that was Sister Silcott, Sister Ryan, the assistance of colleagues and peers who contributed through feedback, proofreading, technical support. Your help has been invaluable. And to go a step further, Dr. Blake was one who assisted me, and you had Dr. Tiffany, Dr. Buffon, and a few of my colleagues. So thank you to everyone who made this possible. Questions? Questions or comments, which I hope not.
Thank you, Nurse Gray, for giving us some insights on the impacts of COVID-19 on our nurses in the United Kingdom. And we can never undervalue the work and the contributions of our nurses. They are our local heroes, and without them, I'm not sure how we would survive in this country. And so, thank you for your contributions. We salute you. Any questions? Thank you. Moving forward. So there's been a slight change in our program, but we're way ahead of time, and so we're going to ask our next presenter, Mrs. Carrie-Ann Weeks, one of our newly qualified registered nurses. She will be coming to present to us today on the impact of brain drain on healthcare in sub-Saharan Africa. Nurse Weeks.
Good morning, everyone. Thank you, Charisse. So, I recently graduated from the All Saints University School of Medicine in Dominica, where I completed my bachelor's degree in nursing. And during my final year, I had to do a research project. And I didn't do this by myself. I had a colleague who we did it together, and her name is Rhoda Falana. And what we did was a review of the impact of brain drain in healthcare services and the roles of government policies in hiring healthcare professionals in sub-Saharan Africa. So our outline was statement of the problem, we did research questions, conceptual definitions of terms, research methodology, discussions of findings, recommendations, study limitations, conclusions. So, we'll delve into the statement of the problem. The global migration of healthcare professionals has created critical shortages, particularly in the rural and undeserved areas of low and middle income countries. Despite government efforts such as salary increases, improved working conditions, and bilateral agreements, brain drain continues to undermine healthcare efficiency. Thus, the challenge is to determine which government initiatives are most successful in keeping medical professionals and lessening the effect of brain drain on the provision of healthcare services. In order to get to the answers what we were seeking for our review, we developed the following research questions. 1, what are the key factors contributing to brain drain in healthcare? 2, how does brain drain affect the quality and accessibility of healthcare services? 3, what role do government policies play in mitigating brain drain and its effectiveness in retaining healthcare professionals? 4, what are the roles of the international recruitment policies in addressing healthcare staffing shortages and their impact on healthcare systems globally? These were some highlighted terms key terms that we use throughout. So one is impact, and this is the action of one object coming forcibly into contact with another. And then we can focus more on brain drain, which is the immigration of highly trained or qualified people coming from a particular country. And the government policies is a rule principle that hopefully better guides decisions, resulting positive outcomes that enhances the community or unit. So how did we go about collecting data? Our data was collected using electronic databases like PubMed, Google Scholar, ResearchGate, which analyze both quantitative and qualitative findings. We used meta-analysis and meta-synthesis. Those were used to analyze data. Descriptive and inferential statistics techniques were applied for quantitative data, while content analysis was used for qualitative data in the reviewed articles. So who was involved in this study? The target population included healthcare professionals in brain drain affected regions, policymakers responsible for workforce policies, and international organizations supporting healthcare worker retention. Who were included in our studies? Studies published between 2019 to 2024, and those were in English. We had ethical approval, addressing policy interventions for brain drain, and included both qualitative and quantitative studies. The sampling technique, a purposive sampling was used to select 30 articles published in the last 5 years, ensuring relevance to brain drain and policy interventions. Validity and reliability. Validity was ensured by selecting papers addressing the study objectives and reliability was maintained by using peer-reviewed publications from credible academic databases like PubMed and Google Scholar. For ethical considerations, ethical standards were upheld by reviewing only ethically approved articles, avoiding plagiarism, and adhering to APA 7th edition citation standards. I will now elaborate on the answers to our research questions. So our first research question was, what are the key factors contributing to brain drain in healthcare? Economic incentives was one, and 70% of healthcare professionals migrate due to significant salary disparities. Professionals in high-income countries earn 2 to 3 times more, with better benefits like healthcare and retirement plans, and this was a research done by Garcia et al. In 2022. Johnson et al. Spoke about professional development. They said that limited access to advanced training and career growth drives 65% professionals to leave. For example, 80% of healthcare workers in high brain drain countries report a lack of specialization programs as a significant factor. Hera et al. Spoke of quality life and stability. Political instability and lack of personal safety prompted migrations, with 55% citing security concerns. Improved public service and health systems abroad attract 40% of immigrants. Further studies showed that unsatisfactory working conditions, concerns about crime, safety, family matters, new experiences, political uncertainty were also some key factors why, the cause of brain drain. Question 3. How does brain drain affect the quality and accessibility of healthcare services? Economic losses. Brain drain leads to a 1.5 gross domestic product, such as annual loss, costing $10 billion in foreign recruitment and outsourcing. Productivity in healthcare drops by 25% due to workforce shortages. The healthcare system gaps. High immigration results in a 30% increase in patient-to-doctor ratios and a 40% rise in patient wait times. Reduced innovation. Countries lose 15% of research output within 5 years, with 30% trained researchers working abroad. Fields like medicines, engineering face significant setbacks. Social and family impacts. Family separation affects 55% of immigrants, with 60% of their children experiencing emotional distress and lower educational attainment. What role do government policies play in mitigating brain drain and its effectiveness in retaining healthcare professionals? Well, we saw that return migration programs were necessary. However, 45% of immigrated professionals express a willingness to return for competitive salaries and career pathways. However, only 20% of these programs included sustained efforts for career growth, reducing effectiveness. Improved working conditions. Enhanced workplace environments, including reducing workloads and improved resources, can decrease turnover by 30%. Healthcare sectors with better staffing and facilities reported higher retention rates. Our final question, we looked at what are the roles of international recruitment policies in addressing healthcare staffing shortages and their impact on healthcare systems globally. Exacerbation of healthcare gaps. Recruitment from low and middle income countries deepens workforce shortages, leaving the source countries with fewer healthcare professionals per capita. Loss of local expertise. A 10% decrease in high-tech exports has been linked to reduced domestic expertise in areas like artificial intelligence and biotechnology. Training capacity strains. Outflow of skilled trainers reduced new healthcare graduates by 15%, impacting the supply of qualified professionals in the affected countries. Now, After completing our review, we came up with a few recommendations we thought would be beneficial in retaining healthcare professionals. 1, the concerned authorities need to develop the rural sectors, thereby providing them with better standards of living. 2, the educational sectors should also be developed, thereby providing career growth, and put health insurance policies in place for both workers and their family members. Study limitations. Due to restrictions on publication date, other vital information in older articles could not have been included in our data. Limited access to data collection sources, we had a small sample size of 30, and financial constraints due to high cost of printing and binding. Conclusions. So, brain drain in the healthcare sector poses significant challenges to home countries, impacting economic growth, healthcare services, and innovation. Montserrat is a prime example of a small country affected by brain drain. Key strategies would include improving working conditions, offering competitive salaries, enhancing career development opportunities, and investing in healthcare infrastructure. Efforts must be made to return healthcare workers, especially nurses, in order to improve healthcare services. Investing in retention of healthcare staff benefits both patients and the overall workforce. Thank you. And those were our from our booklet, we selected a few of our references.
Thank you, Nurse Weeks, for a very informative presentation as it relates to a global issue, brain drain. And I hope that those who are part of strategic management paid close attention to some of the recommendations that should be considered for our workers. Just a plug-in. Any questions at this time or comments? We'll ask you to come to the middle where the mic is positioned. And congratulations.
Thank you, Carrie. Lovely. And I can't stop myself because that speaks to my heart, this sub-Saharan African brain drain. So Montserrat suffers brain drain. Some professionals from Montserrat goes elsewhere, but we also drain a lot of people here. And I do welcome my colleagues from Nigeria and Zimbabwe and Ghana and you name it, my African colleagues, every time I see them, I know where they're here from. And most of our medical professionals, nurses, are from elsewhere. So, okay, we've been preparing and study, and what you say there is right, and you have the beautiful research about different articles. We have lived that in Sub-Saharan Africa. And the government initiative to retain us over there is much bigger than all that. They can pay us whatever salary, but we don't have shortage of staff. We have excess of clients. Excess of clients. The 600 births that we have in Montserrat in 14 years, you get it in one regional hospital in South Africa a month. My last hospital I work with, 600. So when you ask this lady, did you plan the pregnancy? They didn't plan. And in my hospital, my ex-hospital, we have a 36% of HIV infected women in maternity ward. So that's 1 in 3 women will be affected. So the government efforts were far beyond retaining because we have those clients. Because I was paid a very lucrative salary to look after malnourished children that couldn't feed themselves, and the poverty and the lack of water and sanitation, that is the main issues that the governments in Sub-Saharan Africa and other underdeveloped countries face, and obviously the professionals, they cannot cope. And the story of burning out in the UK with PPE, well, we have a lot of deaths in Sub-Saharan Africa without PPE.
Yes, yes. Yes.
So what I'm trying to say is it comes from my heart to say that it's not only about paying, it's not only about the security when you work in the casualty department, and they are not coming the flu children that you don't want to see here in Montserrat because they're coming for nonsenses, like we say in casualty. We see gunshots, stab chest, stab abdomens. All these horrible emergencies that can be avoidable, and they don't need to burn healthcare workers attending that. Much deeper political and sustainable issues in Africa and other poor countries have to be done to retain their citizens and their brains.
Thank you for your contributions. Any further comments or questions? Thank you very much, Nurse Weeks. Online viewers, please feel free to submit your questions. Should you have any, we can take them after our next presentation. Moving right along, our next presenter, the backbone of our research day, another brilliant mind, Dr. Dorothea Hazel Blake, and today she would be presenting on People Are Talking, Are We Listening? Results on an Exit Survey. Today, we would look at how are our healthcare services truly performing from the perspective of the people who use them. Dr. Blake.
Thank you, Ms. Allen. Good morning. Good morning, everyone. And good morning to those who have joined us via our social media posts. In primary care, in secondary care, in any type of provision of services, there are always questions about the quality of care. Are persons getting the quality of care they need? Are waiting times too long? Are staff being rude to them? Are staff treating them impolitely and disrespectfully? And you only have to turn your radios on a Tuesday morning or a Thursday morning, and sometimes you will have a barrage of comments. And many times, it's not the persons who would supposedly have had the experience that has been complained about, but somebody told somebody who told somebody. And you're getting fourth and fifth hand information. So the decision was that we need to be assessing from our very clients what their perceptions are, what their experiences are. And so this is what is behind the research that I'm going to share with you briefly this morning. Now, access to primary health care, as I said, we have 4 health centers, as we all know, and we offer a wide variety of services, and there is anecdotal evidence, both positive and negative feedback is provided. So what we decided to do was an exit survey. In that, unlike in the NHS, what Bill will tell me about, is that they will send out an email from time to time with a survey to some persons who would have access service and say, tell me about your service. But sometimes that survey comes weeks, if not months, after you would have access to service. This was called an exit survey because as the person was leaving the facility, they were intercepted, you stop them, say, morning, how are you? I see you just had a service. Can you tell me about your experience? The advantage of that is, one, the experience is fresh in their mind. And if they're vexed, you're going to know then and there that they were vexed with before they had a chance to calm down. And if they had a good experience, too, chances are they will tell you about it. And so we collected data over a 4-week period, different days of the week, because if you only went on Mondays, then you would only have, to St. John's Clinic, you would only have Dr. Paz's patients, because she's there on a Monday. But if you come on a Thursday, then maybe we'd have Dr. Skerritt's patients, because Dr. Stinnett is on that day. And of course, you ask for consent, and somebody who spoke before me spoke about having unknown people do the interview, and I decided to lay hands on Bill and use Bill, because when we piloted the study some time ago, I was the actual person who stood there and asked the questions. And I wanted to see if there would be a different response to somebody who they don't know from Adam And maybe they would feel a little bit more inclined to just tell him as opposed to telling me, because maybe they like Nurse Henry, and if they say something bad about Nurse Henry, she might get into trouble if it's me. So we used Bill, and he went around, and after getting consent, we use the technology as well. I know it was old school, going face-to-face, but we had little tablets, so you enter the data immediately. And where the client was underage or could not answer, whether for capacity or they were just in pain and not able to speak, if there was an accompanying adult with them, that person answered the questions. So what did we find? Okay. Again, first of all, this is just the raw data. Also health centers, 31 respondents, 74% of which were female. Again, that was highlighted earlier. This reflects who we have. Women are more likely to come to health centers than men. For most services. If it's a particular service, if you looked at it, you would see a different picture. 42% identified as Montserrat. We wanted to see if the responses varied based on your quote-unquote nationality. These are the age groups. You see, we have a wide range of persons accessing healthcare. It's interesting, we talked about older persons. People think that it's only this age group that comes to the health center. Well, now that we have a resident pediatrician, we are aware, because there will people will be sending them, so Dr. Paz will see her patients. But we have persons in that middle population who are also accessing care. So this was good. Reasons for the visit. Again, we asked that basically, overall, what was the reason for the visit? And I wanted to just flag this one here from my colleagues at Casualty. I'm sorry, I had to. You see this? So it is not true that people don't go to Casualty when they have respiratory symptoms. They do come to the health centers, and those who just bypass us and go to the Casualty, that's a different research question that we need to be asking as to what are the reasons for that happening, because they do come to the health centers. And what I didn't tell you earlier, that I think this started, was it March? Yeah, at the end of March, moving to April. What was happening, right? What happens usually right after St. Patrick's celebrations? We had a spike in the ARIs that Dr. Skerritt Fleming was talking about this morning. So we were in the middle of an outbreak that happens after our mass gathering. And so yes, some of the clients were coming to the health centers, and they were, whether they were children brought by their parents or they were adults, they were seen. And you could see there's a wide range of things. General consultation, what's captured in here though, could very well be somebody who had come to see Mr. Bamishile or Dr. Imara. We didn't want to flag. Regular checkups, where specifically, where it says DMHTN, it's those persons who are clients of the clinics with already diagnosed with hypertension or diabetes who are coming to that particular clinic or coming to see their doctor on a monthly basis as one of the services we offer. And a few people prefer not to say, well, within their rights. Yes? And means of transport, again, somebody raised that a little bit earlier. How do people get to the clinics? And what was interesting, most people were coming by car, private transport. People don't catch a bus no more to come to clinic, apparently. I don't know. This is Kudgehead here. So the red ones are the ones who came by private transport, and not very many people, like one person walked to St. John's, as with St. Peter's, and about 2 people walked to Salem. One person at Salem came by taxi. Again, of the ones that we inquired, that we were able to interview. I'm told many, many moons ago, people just walked to the clinic nearest to them. That was the expectation. So this is another important thing to factor in when you hear things like, oh, we should have a clinic. I've heard people say we should have a clinic in, I don't know, Lookout, so we should have a clinic elsewhere because it's too far. Well, people are getting to the clinics, and I'm not sure that putting one right there, because I promise you that even some of the people who ended up at St. John's don't necessarily live in the St. John's catchment area, but that's a different conversation to be had. So we asked questions. We talked about wait times, yes? And so having arrived at the clinic, did you feel like you had a long wait? And so the question would have been specifically, today, statement, no, I did not have to wait long to be seen by the doctor. All of the clients who were seen by anybody else said no. There was only one client who said, waiting for doctor, and I felt that was too long. All right? So this explains it a little better. So this is the statement, and there was a Likert scale where you strongly agreed, there was a neutral, you disagreed, or you strongly disagreed. And without failure, those who came to see the nurse, so it might have been diabetic hypertensive clinic, the psychologist, either one of them, the nurse practitioner, depending on which clinic you were at, 100% of the people said that they did not have to wait a long time to be seen. Again, one client said, while waiting for the doctor was too long. Time spent with the clients. The question was, whether it's, so the nurse practitioner spent enough time with me. Of course, you'd set up your questions so that if early on you're here to see the nurse practitioner, then the relevant question, you know, the laptops can just jump all over the place, right? So if it was the nurse practitioner or the psychologist or the nurse, 100% of the clients felt that the time they spent with that care provider was sufficient. The person took enough time with me. Again, one client disagreed with the statement referring to the doctor. I would dearly love to know if it's the same clients who thought it had to wait too long. And so, done vex already. And I go in, and then lo and behold, this doctor did not spend enough time with me. And I'm going to tell you, I have absolutely no idea which clinic this is, and we don't need to know that. The point it remains that this was a person's perception. There was another statement where the doctor, the nurse, the FNP was willing to answer all my questions during the visit. Again, the statement was made, and they were asked to agree or to disagree. All of the clients who had questions, because there were few who said, had a neutral response and said, I didn't have any questions, so this doesn't apply to me. But for all of those, and again, it did not matter whether it was the nurse practitioner, the psychologist, either of them, or the nurse, they all agreed that they got their questions answered. The next statement was the doctor, the nurse, the FMP, advised me on what to do if my symptoms get worse. You come to the clinic, somebody must give you some advice, yes? Again, 100% of the clients said that the nurse and the nurse practitioner gave them advice on what to do if the symptoms got worse. There were 2 individuals who could not recall being given that advice. Again, not necessarily on the same day or at the same facility, because we put all 4 together. There were a series of questions that tried to determine what do you have. We use the Montserrat term, trust and confidence in the person. And I have confidence and trust in the nurse, the doctor, the psychologist. It wasn't written this way, it was written specifically for who you saw, yes? And all of them agreed, which would make sense because that is the only reason why I'm coming to the clinic. I would like to think. I'm coming because I have confidence that if I see Dr. Skerritt at St. John's, she would treat me well. If I see Dr. Valentine at Cudgerhead, he would treat me well. And there was also a statement that said the nurse, the FMP, the doctor treated me with respect during my visit. All 31 respondents, whether it was the adult responding on their own behalf or an accompanying adult, they all said yes. So, at the end of the questionnaire, and these are all the questions, but these are the ones, selected questions, right? All clients described their overall experience as satisfactory. After having gone through the individual things, we said, all right, so on an basis, the entire experience you had this morning, how would you rate it? And they were all rated as satisfactory. Even my friend who thought that he had to wait too long, overall it was satisfactory. And one of the things we tried to measure as well, because you would know, most of you would know, that at the health centers we have instituted this electronic health information system. And I heard described earlier people coming to the clinics as a social gathering. Initially, when we started trying to insist on appointments, there was a little bit of pushback, but it was simply that people come to the clinic regardless of their times, okay? So if you even said to them, your appointment is at 10 o'clock, I get to work at 7:45 in the morning, and there are a series of people sitting there waiting, because that is what they're accustomed to. They come and they chat with each other, how you do, what happened since last time we met, and it's a social gathering. But we also had, so we didn't want to disrupt that little social dynamic, but you also had to get them to understand that we're trying to give you appointment times, because in some cases now, you had older folks who had people dropping and picking up who were complaining. I don't know what to do. Every time I drop my mother, it takes too long, and I have to go to work, and I have to do this. So you also have to work with the two sides of the family. Mama and grandma want to stay, but the daughter, who is a working adult, who has to drop off and pick up, wants to know, what time can I come back and get her? And so there was a little bit of that dynamic that we have to try and work with. And plus, as we showed you earlier, our clientele are not all 60 plus. We have clients who, whether they're diagnosed with diabetes or hypertension, are working adults and need to be able to say to their bosses, I have a doctor's appointment, so I have to go for 11 o'clock. Yes? So we're slowly but surely getting people to understand that when your appointment is at 8, you come for 8. No, it's not at 8. 8:30, you come for 8:30. If your appointment is at 11, if you even show up at 8:30, unless the people before you do not show, you may have to wait. Of course, the nurse is triage, so if you are more urgent, you will be pulled forward, but traditionally, you try to keep the appointments as they should be. All right, so those who had appointments said it was easy to make an appointment, now that they're beginning to understand, and that they were seen within a reasonable time, and I actually had times, because one of the things you can do with the HIS, if it is used correctly, is that when patient number 1 walks through the door and goes to the front desk to say, I'm here, the person at the front desk, the CHA or whoever, checks them in. The name is in the schedule, thank you. You right-click and you click check-in. So there's a timestamp. So I can objectively see that Dione Mara came to the clinic and she checked in at 9:30. When she goes to see Nurse Henry, and Nurse Henry has done her vitals and put them in, there is also a timestamp. And then when she goes in to see Dr. Skerritt, if the system is done properly, there is also a timestamp. So I can see, if I need to, as an administrator, the average time it takes for the patient from when they've checked in to when they finish their encounter with the physician. You can also see whether the wait time is longer between check-in and vitals, or having completed, do they get their vitals done in 20 minutes and then have to wait 2.5 hours to see the doctor? You can also see that too. So there are opportunities to look at that data as well. This is not what this is. I'm just letting you know all the wonderful, I'm selling the idea to my colleagues at secondary care. You need to get the system up and running. There are opportunities and empirical data too, because if we take this to the next step, when people start complaining about their wait times, there is an opportunity to go back, find that individual and look up and say, all right, what was his check-in time? Maybe the gentleman is right. Maybe he did wait too long. Did he have an appointment, or was he a walk-in? And so, yes, he did have a long wait, because on initial assessment, he was not deemed to be urgent. Therefore, he really had to wait until all the people with appointments were seen and then be seen. All right? So there is a wide range of possibilities that we can explore, but in this instance, we were happy to report that they said it was easy to get their appointments, and that they were seen within reasonable times of their appointment, which is important. There's no point in giving me an appointment and then you tell me come 10 o'clock and you can't see me till 12. There was one thing that hit me, is that one of the questions asked was, if you had a challenge, if Bill didn't come and stop you and say, tell me about this, but you were unhappy with your experience, did you know how you could complain or give feedback? and most people did not know. So that might explain to why they call the radio station on a Tuesday morning. I don't know. Or maybe they will still call the radio station on a Tuesday morning. Or maybe it's why they will turn up to go and complain to their politicians. Not saying you can't speak to your politicians, but I'm saying that should not be the first step. Give those of us who are managing the service an opportunity to explore what the options, what the issues are. Give us an opportunity to try to address those. Then if you are not satisfied, then you scale it up. And that should happen for most things. We also asked them an open-ended question: what are some of your recommendations for improving, reduce waiting time? 2 clients said that. Allow more time for appointments to ensure they not overrun. This person seems to be assuming that the reason they might have had a little bit of a wait was because appointments overran, which happens sometimes. Implement a numbering system. These are usually just one. Some people had nothing to add, but one person did not like the fact that somebody stood at the end of the corridor just calling John Brown. Give me a number. Say number 1 or number 7 or whatever. Again, these are not saying we take every single recommendation. I'm just showing you what some of the recommendations are. Better seating options at St. John's Clinic. They don't like our chairs. We are listening. That is important. If you have to sit there, the issue is if the space is limited, there's not much we can do about the space, but we have changed the chairs over recently enough. Better attempts at identifying the next of kin. One person had a particular discomfort because they turned up thinking they were next of kin of somebody, only to discover that their name was not found as next of kin. And of course, and they're saying prioritization by, this is not how they said, this is fancy words of saying, everybody always feel I'm more urgent than that person, okay? Unless you come in on a stretcher, I'm more sick than you. So, and this was usually the people who were walk-ins. Yeah? So, what do these results mean? My last slide. We confirm what we believe. Most of our clients are satisfied with our services. So it is not true what you're hearing out there that we're not giving good service. Those who have tasted and seen can testify to the fact that it's good service. And where every now and again we do mess up, and we will deal with that. Clients will provide feedback if you ask them. That's the other thing. So if you are concerned about things, ask the clients. Don't just listen to the one noisy person on the program or on social media. But we have education opportunities to train, talk about the triaging, because if somebody's thinking that we should prioritize, that is exactly what we do, but so maybe we need to be explaining that to them a little bit more. The whole issue of next of kin, you do not become next of kin just because you're the daughter, right? And that again is an opportunity to educate, because Dr. Skerritt's smiling at me. She's had some interesting conversations with people showing up declaring that they're the next of kin, when it doesn't work that way. It is the client who determines who is the next of kin, not you because you're the daughter. So, again, opportunity to do that and an opportunity for feedback. And of course, physical space and comfort is important because they say so. I want to acknowledge my colleague, Bill Berners-Lee, who has assisted with the analysis of the data, and he assisted with the collection of the data, as I said. And I should have said, we did not announce to the nurses or the doctors that we were coming on that particular day when we started. They didn't know we were showing up that Bill was coming. Bill is accustomed to being around, so when you see Bill out there, you didn't know what he was doing. Salem is a little bit, it's kind of hard to hide Bill in Salem. So I think nurse figured it out, and maybe shortly after he was there a little bit, I realized, well, why is Bill still here? And then realized what he was doing. But places like St. John's and Cudgee Head, it was easier. We just wait out in the parking lot and wait for them to come. I want to acknowledge the staff of the health centers, because they are a hard-working bunch. Let nobody tell you otherwise. I've worked with them, and I will tell anybody who says otherwise that they're wrong. But I have the evidence to show. And I want to acknowledge our clients who make it all possible. In closing, just to remind us that the government of Montserrat pays your salary and mine. But if you always remember that it is the patient you work for, then you have answered all of the questions, and you will treat them the way they're expected to be treated, and things will improve. Thanks for your attention. I know.
Thank you, Dr. Blake, for offering some insights as to how our service users feel about the services that they receive. And I do think that this is an important mechanism that we can adopt right across the ministries to appraise our performances and to see how best we can improve the services that we provide. Any questions, comments, suggestions? We welcome you to come to the middle and share them with us.
Okay, very good presentation, Dr. Hazel. And I'm Blake, Hazel Blake. I am happy to know that most clients are happy and satisfied with the care they're getting throughout, doctors, nurses, and the other support workers. I'm here sitting and hoping, especially after Mistress Weeks, Nurse Kerry did such a brilliant presentation, that maybe next year we can do one for casualty, just to compare the satisfaction rate of our clients, the public. And in terms of what you said, in terms of patients coming and in terms of their waiting time, even at casualty or at the clinics, at the hospital, you find clients come in maybe at 7 o'clock, 8 o'clock, because their relatives going to work, so they drop them off. And of course, to that person, they are first. They're not thinking that their appointment is 11 o'clock. So you have this conflict sometimes where they say, oh, I was here a long time. But I think we still have to continue this teaching. It's an appointment system, even when you give them the appointment. Yes, it's okay if you come early. Maybe if somebody missed their appointment, you can be filled in, but we go in by the appointment. So you have this, and I find sometimes they come and they will say, oh, I'm here for 8 o'clock. I have an 8 o'clock appointment, and somebody else may say they have a 10 o'clock appointment. But this person who have a 10 o'clock appointment probably came since 8, and you as the nurse know this person is a diabetic. So yeah, you may try to squeeze them in before that other person, and they will say, but my appointment before this person. So it's just education, and even us as the staff, sometimes we have to communicate, let this person know, do you mind, and stuff like that too, for us to have a smoother flow of appointments and so forth. Thank you.
Agreed, agreed. As I said, there are opportunities. I look at them not as challenges, but opportunities to keep educating over and over so people understand. In terms of additional research, I don't know if Sister Fagan isn't here, but a couple of years ago we did an exit survey on the obstetric ward. That's the only one I can recall in recent times, where just as the women were in discharge, having given birth, and they were leaving with their new bundles of joy, they were given a little card, which I had facilitated at the time to give their experiences, and the feedback from that was good, primarily, and the conversation was supposed to be continued. So when you have your spanking new epidemiologist, there will be, I'm sure, an opportunity to continue. I really hope that we can do more of this. Mr. Hurley, are you coming to the mic? Oh, you're coming to the mic? Yeah.
So I really believe in giving credit where it's due. And because of this presentation, Dr. Blake, I really want to take this opportunity publicly to share my appreciation for a few persons, and I'm calling them by name. First of all, Dr. Skerritt. She's been doing a great job. Sometimes I call her, I'm staff, and sometimes I ask her to help me with personal things which she does in her job time, which is really good. but she accommodates me very good, and I want to appreciate her going above and beyond duty to assist me. And I also want to say I had a really, really positive experience with the dental team recently. And I want to commend Dr. Fergus and the dental team for the excellent work they're doing. Great facilities there, and I really enjoyed my experiences. So I want to commend those at this point.
Any further questions? How are our online viewers doing? They're quite quiet this morning. Okay. We are well ahead of schedule. Thank you again, Dr. Blake, and for championing this research activity for the past 3 years, and we look forward to your continued support. Based on our schedule, is it wise for us to? So we have two options. We can break now. We were scheduled to break at. So there's one more. Should we have the presentation? And then you'll have the afternoon to yourselves? I think the ayes have it in this instance. Okay, so our next presenter is one who is no stranger. He would have presented earlier this morning, and that is Dr. Sinclair Coward, who is a former technical consultant for the Ministry of Health and Social Services and a giant within the social work landscape. He will be presenting on enhancing and reintegration of ex-prisoners into society. Dr. Coward, over to you.
All right, thank you. Because we're taking it now, there was 2 colleagues from social services that are going to join me afterwards in probation, but we can fly solo. No, that's all right. I don't think they're busy at the moment. Okay. This is while you're looking, in terms of Dr. Blake's presentation, I wonder when the next epidemiologist comes, in addition to surveying, having an exit survey from those in casualty and on the ward, what about those in the community? Because your exit survey was those who were leaving the clinics, the local clinics. But remember my earlier presentation, a fifth of older people over 60 said they had issues with accessing primary healthcare, not just on the cost, but some other issues that we could have delved into, but they didn't articulate. So, indeed, so I wondered, I know some of your nurses do home visits, perhaps they could be included in the next evaluations, etc. So that's all by way of... Okay, so let's move on to another topic, the final one, enhancing reintegration into society for ex-prisoners. It's not either or, but sometimes it's either or. When you leave prison, either you commit crime and you get arrested and you go back into jail, or you are truly rehabilitated and you live a life of crime thereafter. So this was a small-scale research that social services conducted, and it came about because our probation officers noticed the same people coming before them time and again, and they noticed that the people who were leaving prison were having problems. They were struggling to reintegrate with society for a number of reasons, and they wondered why, and so hence the study to look at why people, or rather than frame it negatively, how can we enhance the reintegration to society for ex-prisoners to try and tackle some of those barriers in society to help them thrive and integrate. So we conducted a study. It was a mixed method study, meaning that we had 2 ways of getting that information. We individually interviewed prisoners, and then we had a focus group where the people who answered those questions earlier, one-to-one, now could do so in a group. And I'm going to summarize the questions for you, well, the responses for you now. So we had 2 main research questions. What challenges do ex-prisoners face when they attempt to rejoin society, and what strategies can we use to try to reduce those barriers? Just two main to-the-point questions. The strategy, the sample strategy we employed, we took who we can get, and there's a few characteristics of those prisoners ex-prisoners that we employed. So it was both purposive and convenient. So they had to have spent more than 1 year in prison. They had to be aged over 18 and were resident in Montserrat at the time of the study. Prison records were searched going back to 1990s, and we identified over 100 people who met those criteria. We then excluded people who had a mental illness, who were no longer resident in Montserrat, and those who declined the invitation to participate. And so from 100, that came down to 15, 1-5. So we took what we can get, literally. Okay, so what did we find? What did we find? So when we asked them whether they had any pre-release programs, activities, to prepare them for re-entry into society, out of the 15, most said no. And a scattering of the rest had some kind of input. We asked them whether they felt, putting that same question another way in a sense, whether they felt well prepared for the release, and the same number, which was consistent, said no, they didn't, because of course they felt they didn't have any preparation. However, another question we asked, what are some of the programs that you were exposed to for your release? Only 5 here now said none. Well, that's interesting, and in research you may say that lack of correlation can sometimes threaten the validity of your study, but we had a two-pronged study, triage they called it, so we also had a focus group, so we were able to get people to expand and through discussion let us know exactly what they meant in terms of the individual interview and to expand on their responses. So the focus group followed the individual interviews. By that time, we had already analyzed the discussions, the responses from the interviews, so we knew this discrepancy was there. So we particularly got them to expand on reasons why they felt they didn't receive. And so we were able to limit any damage that lack of correlation may have had. Okay, so, and of course, the question may have confounded. It could have been the question confused. That's the lack of consistency. But, so 5 said no there, and a number said that they received counseling, what else, religious input, farming, maths and English, and road work. So they did receive some kind of preparation before they left jail. Who or what helped you when you returned to the community? Most was friends, family, social services featured, church, and employer. In terms of what are the most pressing issues for ex-prisoners, jobs featured very highly, and finance. So the basics, you need a job. And those two are linked, and housing, of course. And once you get those two, the other one normally follows. But immediately on leaving prison, of course, you need somewhere to put your head, and then you need some money and something to do during the day. So there's another, other issues there in terms of not re-offending was an interesting one in terms of recidivism, as they call it, when leaving jail is a thing, it's an issue, and when you ask ex-prisoners what the most pressing issue for them, and they say it's not re-offending, that's an interesting response. So they're aware that there's a possibility that they may go there. So they're saying we need help, in other words, to try not to do it, So what are some of the most difficult issues that you personally faced in return to the community? Employment, of course, is a very strong theme. That was very strong. And stigma raises its head here. Stigma kind of dominated the focus group. So whereas you can only tick a box here or say yes or no, they could expand on stigma, and they had a lot to say, stigma in the focus group. And yeah, they had a lot of colourful stories and horrific stories about how people would be very discriminatory to their face without shame. They were ex-cons, they were ex-prisoners, and people treated them as such without any social niceties or without protection of the law. That was something that came across, that they couldn't take it, they couldn't complain or go somewhere. It was just something that happened, something that they were expected to suck up. So, and you know, they used colourful language during that discussion. So these are some of the issues. I'm not sure, you may have your view on how we can tackle that. Good. This should have been up before. Yeah. So employment looms large. And as I said, stigma rears its head. This is in the quantitative response, but as I said, qualitatively, when you're talking to them in a focus group, that's when their feelings come out and they can bounce off each other to say, yeah, that person said the same thing, or when I went back to my old employer to try to get my job, they said this, and I couldn't believe they said this to my face, etc. Those kind of anecdotes that came out. Now, you may feel that that's okay, that they did whatever they did, their crime, and so they deserve to be treated that way, or you may feel that they did their crime, they were punished, and now so let it go. But it's a thing not unique to you, Montserrat, of course, around the world. They're struggling with this, but often prisoners are protected by legislation and law elsewhere in terms of spent convictions, in terms of information being passed on. For vulnerable jobs or for sensitive jobs, you know, you have to have that police check, and so working with vulnerable people, you can't avoid it. But often the employer has to make up their own mind about risk. So it's a big area, When asked whether they felt discriminated against during their job search, quite a few felt they weren't. And maybe, I mean, we reflected on this and wondered whether everyone had the same perception of the term discrimination than others, because mine and yours understanding of, or perceptions of what it is to be discriminated against may differ. And, you know, not all employers are going to tell you why they didn't offer you the job or give you an appointment. But if you didn't get that, you may automatically feel you were discriminated against, or you may have had some other kind of evidence, some clue, or maybe just the sheer fact you go for job after job and not getting a break, that you assume it must be discrimination. But aside from all those possible reasons for the response, this was the response. So 2/3 of it. 2/3 of our sample felt they were not discriminated against. But, yeah, okay. However, at the time of our employment, at the time of the interview, 2/3 were employed, which matches. So we wondered again whether once you are in employment, the hardship that you went through to get that employment fades. And it's only those who continue to be employed, because that split matches exactly those who felt discriminated in their job search and those who felt they weren't discriminated. So maybe those who remained unemployed said, I'm unemployed because people are not giving me a break and they're discriminating against me. Maybe. We may need more questions and another study to answer that. But those who are employed, these are the splits for those who are employment and those who are unemployed at the time of the interview. So what kind of help did you need but did not receive? Financial help they didn't receive, they perceived, and 4 felt they needed no help, and you know, help with passport and help with fitting in, help with housing and preparation for release featured. Unemployment took a little back seat to financial, and that they didn't need no help. Okay, so what do we make of that? What do we make of all that? So, research question 1. What challenges do ex-prisoners face when attempting to rejoin society? We found that employment loomed large. That's the main challenge they faced. It was quite clear. Many Montserratian ex-prisoners also felt that the stigma and discrimination weighed on them. And that, as I said, features heavily in international literature. Many countries have yet to tackle. They pointed out, especially in the focus group, how Montserrat's small size, they feel, exacerbated the above issues. You can't be anonymous in Montserrat. If you go to jail, everybody would know that. And you come out and you're trying to get a break, understanding that you have a clean sheet, even if you haven't declared, because most applications for a job ask you to declare that. But if you haven't declared, that doesn't mean that the person interviewing you doesn't know who you are and your background. So they feel that's a big issue in Montserrat. So other issues impacting ex-prisoners included housing, finance, the lack of good advice, again trying not to reoffend, training and access to food. That was in terms of what challenges they face. Employment looms large. In terms of what strategies can be used to reduce the barriers, the prisoners themselves said, unsurprisingly, they would need more help with employment support, skills training. They need more guidance and support, more financial help, and this is taken in the context that majority of them, 2/3, 10 out of 15 reported that they received no support at all. And in the region, we looked at, because there was also a literature review that went with this, where we took account of the regional situation in terms of reintegration. We found that most Caribbean countries provide next to no preparation for release for their prisoners. So, but that doesn't mean that we are, because we've got company, that it should go untackled. But most Caribbean countries don't provide much in terms of releasing their prisoners. That may explain the high rates of recidivism out there. So what to do about it? So we feel we need to develop, or somebody does, probably the prison, social services, and other stakeholders, whoever else needs to be involved, individualized pre-release plans for every prisoner, map their strengths, their weaknesses, what they need in prison, what family support they have perhaps when they leave, whether they've got housing that's still there that they had before they went, all of that, take it and put it in a plan and support them in the transition and beyond until they find their own feet. So every prisoner needs a support plan, implement a wide range of programs inside prison, preparing them for release, training, education, employment, etc. We need a coalition of civic organizations. Red Cross can become involved, any other charitable agency or private agency or Rotary or agencies like that to assist in the delivery of pre- and post-release programs for prisoners. I think that's beginning to happen now. We need to launch a public awareness campaign aimed at tackling the stigma, discrimination that's faced out there by these individuals. Ensure there's a well-defined policy from the government of Montserrat to support this work with an associated budget, a monitoring and evaluation system to track progress while action is taking place. We need to ensure new prisoners, as soon as they're in prison, understand their rights to rehabilitation, to the classes and the programs. They can refuse to take part, but they should have rights to education. Most prisoners, I'm not sure in Montserrat, I'm not sure whether there's much research done here, but around the world, most prisoners are found to be illiterate. Most prisoners are found to be, have substance abuse or misuse issues, so they have a burden which makes them unattractive to employers anyway. And then you add to that a prison person, then that just adds to their load. So they need guidance, they need advice, they need to know how to access programs, who to talk to, and if they got any redress including to an objective external body, should something in prison in terms of interfere with their rights to these programs. We should provide dedicated substance use treatment programs. I'm not sure whether that happens already. I know we have some psychologists, I think, that goes into the prison, regular counselling. Do we do sex offender treatment? In other words, do we give these prisoners who have needs, medical, psychological, physical, do we treat them and prepare them for when they leave, when they transition out, so that they're in the best possible position to rejoin society? That's the question. But what have we here? What have we here? So what we have here is in June, not a few months ago, there was the launch of a program called the Reintegration to Society for Ex-Offenders. You can see our governor here with a prison superintendent launching that in June, only a few months ago. So it's called RISE, as Cherise said, the Reintegration to Society for Ex-Offenders. And Minister John Osborne was present and when he launched it, and he said former inmates often face limited access to jobs and education. They also face stigma and suspicion from the public, leading to psychological and social challenges, including the risk of offending. So it's quite right. It captures what we are looking at, basically. And what RISE does, it includes educational, vocational, psychological, mentorship, peer, employment, everything that we found is needed in our research. And ongoing monitoring is also built in to the program. And I understand as of June, the program had 12 participants, 8 inmates, 4 ex-offenders, and they're all involved in some kind of academic class in maths, English, ICT, etc. And we applaud that because exactly what we want. However, my only thing is that imagine we were doing our research and then towards the end of it, we came across that something's going to be launched in Montserrat exactly on the same research that we were doing. And then we wonder, how could that be? How could these two initiatives exist oblivious of the existence of one another? So it's all, that's madness. So, so I'll just put a few notes on this last slide to say that this kind of lack of joined up working, lack of coordination, it's not good. Between ministries and departments, I don't know who to blame, but what it can do, it can result in wasted resources, you know, duplication and missed opportunities, because RISE is led by the department, the Community, Youth and Sports Services, sorry. So they are providing a practical response to this problem. They've got to work, and I'm glad for them. But social services, we did this study, we interviewed ex-prisoners, and we have put together a literature review where we took into context the regional and international literature, and we put that together, and we feel arguably, so it's empirical evidence we've provided, that both of us would have been stronger in a collaboration. Both of us would have been stronger. Perhaps armed with this research, with this evidence, RISE could have unlocked additional resources from somewhere and taken on more or wider or better work. So the fact that both of us operated in parallel, oblivious one to the other, is regrettable. But don't get me wrong, it's great. This is concrete action being taken against an issue that we identified as a problem in Montserrat. But we should always also find ways to link up research across GOM, not just, and you know, DCYS is very close to, are they in the same ministry? I don't know. They're not anymore. Okay, they were in the same ministry, so it's very close. And some of the same, sorry? It could be the link. But some of the same individuals, Montserrat isn't a big place, and but what we have to do is to ensure that this stuff like this doesn't happen in future, that we find a way to communicate across ministries and across departments where people are involved in the same or similar research, there must be some kind of mechanism or way that we could find that out, that we know about that, to save duplication and get stronger. That's my only plea at the end of this. And so I'm great, some action is happening, and RISE is more than welcome to our report, to our empirical evidence, so maybe they can grow and expand as a result of this. So, but thank you all for listening anyway. Thank you very much. Thank you.
Thank you so much, Dr. Coward. And just to add, there has been some progress. There's actually a task force, and so they do have some meetings, and there's now representation from the Department of Social Services. So I say kudos to the probation officer listening, Mrs. Sharon Lewis-Williams. She is a part of those meetings. But I do agree, there is scope for wider collaboration, and so we encourage that from the Ministry of Health and Social Services standpoint. We know that reintegration is one of the toughest and most important challenges after incarceration, and so we would have taken notes in terms of the need to strengthen the infrastructure that we have existing for inmates who are being released and to support the transitional plan. Any questions, comments for Dr. Coward? Now is the opportunity to do so. And thank you so much for putting together all the data and recommendations. We appreciate your contributions, even from afar. Anything from our online viewers? I know we have some competing demands today, and so that could be the cause. We did say at the end of all of our presentations that we would open the floor for further questions. So we can ask persons, if you do have a question, you can come to the middle, centerpiece there, and let us know what questions you have. Or any comments?
Good afternoon. Yes, it was a comment, not a question. It was when Dr. Coward was presenting on the elderly. We recognize that our population is getting older and older, and it poses a lot of problems because our care home, which is the Golden Years and Magotson, they're practically full or filled. And so when persons, especially the older person, becomes hospitalized, we recognize also that it's a challenge, especially when time for discharge. They cannot, there's an issue of them returning to their homes. And so one of my comments was that we could look more into getting more carers. There was a comment when Dr. Coward was presenting that need for more training of carers. And I also recognize that some persons, yes, they do assist in the home, but they're there as cleaners and not so much as carers. So they are limited as what they can do, especially for the elderly. So it is, just about, we have to think more strategically now in terms of what are we going to do in terms of providing care for persons in their own home, and also keeping them out of, well, there's not much of care homes because of the spaces are limited now, or practically there are none. And in terms of taking up a bed space in the hospital, that is much needed for persons who are sick, we need to really look at how we can help our people in terms of staying and be cared for at home, and, that kind of thing. So that is what my comment was really about. I don't know what others have to say, but really and truly we need to really take a look at that. Thank you.
Thank you very much, Nurse Lady. Any feedback from you, Dr. Coward?
Well, there's two issues there. There's discharge planning and
Can you come to the middle so that our online viewers can hear you? Just to support the online viewers. Thank you.
Okay, well, no, that's a good comment, and it raises two issues, one about discharge planning, one about carers. I remember in a meeting previously about carers, where I think many people in here would remember that we said we were going to go down the route of getting a register of trained carers that can be used to meet the need that we know is coming. I'm not sure what happened to that. I know that we're training carers, some training for carers are being rolled out, but I think those carers at the moment are in the group homes. It's not open to people in the community as yet, and to informal carers, family members, etc. That's who we need to involve, because without them, it will fall back on the state to care for these people, or people will be at risk at home without the proper care. And in terms of discharge planning, in terms of the group homes being full up, people who can go home being stuck in hospital because they haven't got the right care, that's an issue. I know UK discusses that all the time. They call it bed blocking, and they throw a lot of money at it, and they still can't get it right. I don't know what Montserrat can do except to put those two issues together, train an army of carers, perhaps, and then dedicate them to try to keep people in their own home. And then you have to involve housing too, to get involved, to adapt showers, adapt walkways, adapt the homes so that you can live there with disability. That they may be the two ways forward.
Thank you very much, Dr. Cord, for those responses. You have
Good
another
afternoon.
person?
I have a comment on the same presentation with the elderly with regards to what Nurse Weeks mentioned about having day centers. In the UK, they call them day centers, so it's not really here, but they call them day centers, and they have buses that picks up the elderly from their homes, take them to those centers, and they have music, they have games, so these people are engaged. So it's like us going out to work 8 to 4, those persons are picked up and they're there for 8 to 4. They get their meals, snacks, and then they're taken back home in the afternoon. So these are out there, so we could just kind of look, source, fashion, and adapt.
I agree with your sentiments. I think we have the miniature version of that, hosted by the Senior Citizens Association. I'm not sure if it's once per month. And I know recently the Lookout Warden Support Unit, they started to have more regular activities, I think on a Friday. But the wider issue is funding, always cost implications. And so we are calling on the community to see in what ways they can contribute. And you know, if you have resources, even your time, you can volunteer your time and visit them on a Friday and give that support. So we welcome that support from the Ministry of Health and Social Services. Any other questions or comments? Okay, so it was a very interesting and stimulating morning. We saw some recurring themes, a call for further public sensitization, policy reform, accessibility, collaboration from the community and NGOs, routine checks, screenings, further research, monitoring and evaluation mechanisms, and budgeting, more finance needed. Thank you very much for your participation. You have been a very lovely audience this morning, amidst all of the competing demands that we have here today, funerals and other stuff. And so we thank you for your participation, those of you who would have participated. We hope that next year we would see you again in whatever capacity you choose to come in. And now I will hand over to Mrs. Penny Maloney, our Health Promotions Officer, to give us the vote of thanks.
Okay, good afternoon, everyone. I am just here to give some brief acknowledgements and thank yous before we leave. So we've come to the end of Research Day 2025, and I think we can all agree that it was a success. Yes? Yes. So first, permit me to thank our chairperson who very ably led us, and I think she did an excellent job. We agree? Yes. And to our presenters, your passion for research and improving healthcare was evident today. Even the studies that weren't locally based, I think there's a lot that we can infer and take and better our landscape of healthcare here in Montserrat, and it was indeed an inspiring morning. So can we give our presenters a round of applause? And thank you for sticking to time and even going below time and permitting us to end early today. So I have to acknowledge, of course, those who worked behind the scenes. We have Jonique Morris. She is our clerical officer extraordinaire sitting there at the back. Bill Berners-Lee, we heard his name countless times throughout the day, and he consulted with the researchers, he collected data for himself, he was sending out emails encouraging persons to participate. So can we give him a big round of applause, please? Our technical team, we have iTech, I see Ivor Greenaway and Naren Bob. We also have GIU here today, Philip Braid and Lana McDonald. We have to say thank you to them as well. So we had some fruit snacks, a nice healthy snack that was provided by Mrs. Cheryl Castle. And downstairs there is a delicious lunch waiting for you, provided by Marilyn Boatswain. And we also have to say thank you to Cultural Center for providing us this very clean and cool venue for us to use today. So can we give them a round of applause as well? So I have one special acknowledgement here. We cannot leave today without saying a very big thank you to someone without whom Research Day might never have been possible. And this event is her brainchild, it's her passion project. And indeed, I believe it's a part of her rich legacy within the Ministry of Health and Social Services. Who am I speaking about, ladies and gentlemen? Yes, Dr. Dorothea Hazel Blake. So for the past 3 years, she's worked diligently to ensure that Research Day is not just successful, but it's a flawless event. Because of her vision, I think it's a very much anticipated event on our annual calendar. And her commitment has strengthened our culture of research and evidence, helping us inform policy and patient care in ways that I'm certain will benefit generations to come. So your role is acknowledged and appreciated. Can we stand here today and give her a big round of applause as we say goodbye? Thank you very much. And a final thank you to all who joined us here in person and online. I hope you are leaving here inspired, informed, and just a little bit better than you came. Enjoy the rest of your afternoon.